All right, good afternoon, everyone. Thank you for joining us for the last workshop of our second week of the annual meeting on Tuesday. Today, we'll be talking about removing barriers to healthcare. So this panel is led by Senior Attorney Anastasia Bowden from the Pacific Legal Foundation and the VP for Strategic Outreach and Communication, Lindsay Killen at the Mackinac Center. The panel will be moderated by Iowa's Speaker of the House, Linda Upmeyer. So over the last few months, due to COVID-19, ALEC has been receiving several questions from our state legislators about current regulations that are impacting the healthcare industry. Many of our legislators are concerned that there could be a lack of healthcare providers, beds, and medical equipment if this pandemic continues or gets worse. In this session today, our policy experts from the Pacific Legal Foundation and the Mackinac Center will be highlighting policies and regulations currently stifling access to healthcare providers and equipment. They'll be touching on the following reform options during their presentation, talking about removing certificate of need laws in the states, which places a barrier that restricts the use of medical equipment for healthcare providers. We'll also be touching on removing barriers to telemedicine, which is a growing and hot topic here in DC, but also in the States, and expanding scope of practice, which would provide patients with greater access to healthcare providers. Before we kick off the session, I'd just like to walk through a few housekeeping tips. So if you'd like to ask any of the panelists questions during their presentation, you'll be able to submit questions via the chat box or the Q&A box, which you can find at the bottom of your screen on Zoom. We'll be getting to all the questions at the end of their presentation. Also, just a note, we'll be using the chat box feature to provide handouts and policy resources that the Pacific Legal Foundation and the Mackinac Center have released over these last few months. If you're interested in rewatching this workshop, please note that we will be distributing this panel through ALEC Connect later on this week, and we'll also be releasing it on our YouTube channel, which is youtube.com/American Legislative. We can also send this video to you personally as well when it's released. Now to kick off the panel, we'll be having the Iowa Speaker of the House, Linda Upmeyer, just give some brief introductory remarks.
Good afternoon. It's such a pleasure to be here talking about this topic. I think Josh is absolutely correct. We've had a lot of discussion about some of these questions as we've moved forward. And so first of all, I'd like to tell you a little bit more about our experts that are here with us today. Anastasia Bowden is an attorney with the Pacific Legal Foundation Economic Liberty Project, where she challenges anti-competitive licensing laws and laws that restrict freedom of speech. Anastasia's practice largely consists of representing entrepreneurs and small businesses who find themselves in a bureaucratic nightmare, which we've all observed, when they're simply trying to make an honest living and do their work. So one of the most egregious examples of the laws she challenged are the competitor veto laws, which I'd love to hear more about as you talk, Anastasia. Anastasia has represented companies like in these competitor veto lawsuits across the country, achieving legislative reform in Montana, Pennsylvania, and West Virginia. In addition to litigating, Anastasia testifies before legislatures on the impact of occupational licensing on entrepreneurship. Her writings on all these matters of law and liberty have been featured in the Washington Post, the Chicago Tribune, Forbes, the Wall Street Journal, and many more. We also have joining us today, Lindsay Killen. Lindsay is the Vice President for Strategic Outreach at Mackinac Center for Public Policy. In her role, she oversees strategic development for public policy initiatives, state and national coalitions, and engagement with Mackinac Center's priority issues. Prior to joining Mackinac Center, Lindsay was the Director of Policy at the Beacon Center in Tennessee, where she worked directly with the President and CEO to develop annual policy initiatives, oversaw the publications of all the policy briefs, reports, special studies, and acted as the center's liaison to the members of the Tennessee General Assembly. Lindsay's been working in the free market public policy movement for over 15 years, beginning her career in Washington, D.C. with Freedom Alliance, later working as an editor and coalitions manager for townhall.com and new media director for Mercatus Center. In 2010, Lindsay left Washington for the West Coast, where she directed marketing and communications at the Independent Institute in Oakland, California. Her popular columns have appeared in Politico, Forbes, The Hill, Daily Caller, the Washington Examiner, Washington Times, and others. As a native of East Tennessee, which I'm sure took her back to that state for a little while, she and her husband, Jeff, reside in Midland, Michigan, and their one-year-old daughter, Viola, and they have a golden retriever, Leonore. So welcome, ladies. You know, in my time as a legislator, I don't know if I mentioned this before, but my very first kind of leadership initiative was chairing the Health and Human Services Committee. So CON was a common topic, pros, cons, what we should do, where we should go, big topic every year. And then increasingly over the years, issue related to access. So whether it was telehealth, whether it was scope of practice issues to get more providers into our rural communities, those were all issues we struggled with. As you may know, Iowa has one of the most expansive laws for nurse practitioners to practice. I happen to be a nurse practitioner, so we enjoyed that, but I'm sure there were other places where we could have expanded scope more. So I'm going to begin, if it's okay with you. Anastasia, would you please begin with perhaps talking a little bit about CON and some of the other topics and your work, and then we'll hand it off to Lindsay.
Sure. So we call certificate of need laws at my work competitors veto laws, because essentially what they do is they are aimed at making businesses prove that there is a need for their business before starting up. But the way that the government determines need is by inviting all the existing businesses to show up at the hearing and say whether they think a new provider is necessary. And in effect, the existing businesses almost unilaterally say, no, we don't need any new competition. And that's the determining vote to whether CON is granted. So we call these laws certificate of need laws. And we see these across various industries, transportation, of course here, healthcare, sometimes with apprenticeship programs, even charter schools. But it's really problematic in an area like healthcare, where potentially life-saving services are on the line. And just to add hospital beds in some states, if you want to buy an MRI machine, if you want to build a new hospital, if you want to build a new surgical center, you have to go through this onerous and anti-competitive certificate of need process. And we find that it's really limiting the availability of healthcare services. And so it's my job to represent these entrepreneurs and try to get these laws struck down in court.
Lindsay, what have you been working on?
Well, we also focus a lot on certificate of need reform. We do feel that it is an area that needs very, timely attention from state lawmakers, particularly given this national, this most recent pandemic with COVID-19. But these laws date back to the 1970s and actually stem from federal action in 1974, when the feds came in and they were trying to control healthcare costs and reduce redundancy in the healthcare marketplace. So they put these laws in place at the federal level and mandated that states adopt some version of them at the state level in order to continue receiving federal funds for their healthcare programs. So states did that. And by the early 1980s, they realized these laws just aren't having the impact and the effect that they were designed to have. And in fact, not only were they not controlling healthcare costs and keeping those costs lower, they were actually very likely making costs rise for patients. So they were having the opposite effect. And they promptly repealed these laws during the Reagan administration, which I think goes to show you how very clear it was that these laws had failed to achieve their goals. I mean, when does the federal government repeal anything of that magnitude? So, but that left the states to have to repeal their state level regulations. And a number of states did, but 36 states have failed to do the cleanup work. And unfortunately, over time, special interests have settled in and have fought to keep these laws in place and have done so very successfully. I mean, let's just put it in practical terms. Let's say that in your town, there are 2 grocery stores, Kroger and Whole Foods, but Aldi would like to open a store in your area. So representatives from Aldi go before a government commission and have to justify why they should get to sell you groceries. And at that hearing, representatives from Kroger and Whole Foods also show up and they defend their turf, and they claim Aldi is not necessary because both stores already sell groceries, including all forms of groceries you'd probably find at Aldi. Or let's say Kroger, which is already operating in your town, decides they want to expand their vegan food section. Whole Foods can show up and declare that they've already got an extensive vegan food section, so Kroger is not necessary. So the laws are really just absurd on their face. But let's not forget that even to go before this commission, Aldi or Kroger would have to pay thousands of dollars depending on the total cost of their investment plan. So it's a very costly process, and it's basically become a pay-to-play game. And what happens is that it favors the establishment. It favors the larger corporations who can actually afford it. And it's really about who has the right connections. And that's that special interest political game that these the debate over con reform has become.
So as you know, we have not been able to repeal it in Iowa yet at this time. So we're still working on that. But one of the arguments that you can help me debunk, because of course I hear many arguments that sound logical on their face. One of them is that if you have, without a certificate of need in a rural part of the state where there isn't naturally much competition, if a group of people build a surgery center, they will skim off the easy cases, the ones that we typically think of in a surgery center that won't get hospitalized overnight, same-day surgery kinds of things. And then the hospital that is in existence is left with the ER, the intensive care units, those kinds of things that are often, high cost, and probably they're loss leaders. So help me debunk that argument.
Well, I can start, and I'd be interested to hear Anastasia's perspective on this as well. But the data just simply doesn't support that being a problem. In fact, most hospitals' revenues are their largest revenue streams typically come from their acquisitions of clinics, and things like oncology clinics, for example, are very lucrative for hospitals. Small surgeries and procedures really aren't incredibly lucrative. And even that said, hospitals tend to have a multitude of revenue streams that allow them to counterbalance, having to, have consolidation in certain areas or competition in other areas. But the fact of the matter is that we know competition benefits patients, and we should be talking about what's good for patients and not what's good for the hospitals. Hospitals can learn to adapt to a system, and of course they have, to the system that we're in now very well. And they have proven that they've been able to make money year after year after year, even after a number of them have come to your office, I'm sure, as speaker, but also to a number of lawmakers' offices around the country and have told them that they're going to go under. You hear that often from hospital associations, hospital representatives, but year after year, they tend to make it. So I think we need to focus the conversation on what benefits patients, and we know that what benefits patients is competition in the marketplace. It gives them more options, and we need to worry more about that and less about how the hospitals are going to adapt.
Anastasia, did you have something you'd like to add to that?
Sure, I'll just add that Lindsay's absolutely right. The research just doesn't bear that out. There are few rural hospitals in states with con laws. There's less money devoted to charity care. I mean, the facts don't lie, just look at the data. And especially they do these studies as compared to non-con states. And we don't see in non-con states hospitals going out of business in these rural areas. We see them doing just fine. So it just doesn't bear that out. But also, if you think about it, it's a funny way to go about solving the problems that these con programs allege to be solving. There's just an obvious conflict of interest in it. And in practice, they're deferring entirely to whether there's a protest on a new application and whether the protestant themselves states that new competition is necessary. There's not a lot of independent analysis that goes on. So the system's just set up to be an entirely anti-competitive process that insulates the providers from competition when they don't want it, rather than something that's allegedly providing the adequate supply. But in every other industry, we usually defer to the entrepreneurs themselves to determine when more competition is necessary. And we see that competition leads to efficient outcomes, that it is a driving force of innovation and adequate supply and lower prices. And so that's really the solution for all of these problems that con laws are allegedly trying to solve.
So that sort of raises in my mind another question related to this topic. When you look at this, based on what the two of you said, are these con laws even constitutional?
Well, I would say no. Con laws are not constitutional.
Okay, good.
And that's because they violate the constitutional right to earn a living free of arbitrary burdens. As we've spoken about, they're not related to protecting the public. They don't keep costs down. They don't improve quality. What they do accomplish is they act as an anti-competitive barrier to entry that shuts out new businesses for the explicit purpose of protecting the incumbents from legitimate competition. And protecting businesses, this sort of cronyism without any connection to a public purpose, is not a valid exercise of the state's police power. And that's why we litigate these cases, and that's the theory that we bring. And we're aiming to set the precedent at the nation's highest court that doling out favors is not a legitimate use of power, and instead that any law that restricts your constitutional right to earn a living must bear some rational relationship to a genuinely public purpose, and that just does not bear out with con laws.
So can either of you perhaps maybe tell us a story, give us an example of what you've seen in your work around the country in specific states? Anastasia, would you like to start, or?
Yeah, either way, I'd be curious to hear Lindsay's stories too. I'll just tell two really brief stories. One is about Philip Truesdell, who's over in Ohio, and the second is about Ezra's Nashim, which is an all-female Hasidic EMT squad that's been stifled by con laws in New York City. So with Philip, he's my client based in Aberdeen, Ohio, and he started an ambulance company with just one ambulance. And in less than 2 years, he had grown that company to 7 ambulances. He's located 1 mile from the Ohio-Kentucky border, so he's very often called to do trips from Ohio into Kentucky and to take people back from medical appointments with his ambulance from Kentucky to Ohio, or he gets calls from Kentucky because there is a lack of ambulances there because Kentucky is a con state where people have long waiting times and they call him up asking for an ambulance. But he does not have a certificate of need. So of course he applied, and you know what happens next. The existing businesses protested his application and he was denied a con to operate in Kentucky. And of course there's no argument that has anything to do with his capacity or fitness. He's built a great, very well-run, successful company in Ohio with no complaints. He was denied simply because of anti-competitive reasons. And, that's stifling his American dream. And for Philip, who's entirely self-made, it's been, he was shocked to find out that the con law existed in Kentucky. We asked him, who do you think should be able to run a business in America? And he said, anybody who's got breath in them. So he thinks that opportunity should be for everyone, not limited to the powerful few. And that's why he's brought his lawsuit. But over in New York City, we also had a very interesting case where there was an all-female EMT squad that operates in Borough Park, which is in the Bronx. And these women had to already overcome several odds just to form their EMT squad. They had to battle a lot of cultural norms. But the reason that they fought so hard was because Hasidic women place a very high value on modesty. Many of these women have never held hands with anyone other than their husband. And so it can be very traumatizing for them to be thrown into intimate medical situations with men. And so these Hasidic EMTs wanted to provide service to these women so that these women wouldn't be afraid in some instances to call up EMTs. And so they did that, and they were operating for a while, and they then decided that they wanted to expand not just to be EMTs, but also to transport the women to the hospital. So they didn't have to call up somebody else's company and wait, once they got there for an ambulance, they could just transport the women themselves. But New York is a con state, and so they applied for a certificate. They were protested by the all-male Hasidic ambulance squad there, and they were denied. And that's because the local ambulance board said, well, you may think that you need another business. You feel like your needs are not being met, culturally, but really the determination of whether a new business is needed is our call. And we've determined that based on these protests, there's truly no need for another business. So you can see how demoralizing it is, not just to the women in that community who now lack access to care that they feel that they need, the type of care that they would like to choose, but also to these female entrepreneurs who, this work is central to their identity and sense of fulfillment, and they're being shut down because of the con law in New York City.
Thank you for that. Those are interesting stories. Lindsay, I'm sure you've run into some experiences that we'd love to hear about as well. So what have those been?
Yeah, just a couple stories from my time here in Michigan, even more recently with what I call mission creep for the Certificate of Need process. We had a situation here in December, actually, where the State Certificate of Need Board intervened to block access to an innovative cancer treatment known as CAR-T, which is an FDA-approved procedure that programs the body's own T cells to attack and kill harmful cancerous cells. And that allows patients to avoid invasive surgeries, chemotherapy, and radiation. States across the country have started to provide this treatment, and they have not regulated it as a form of con, of course, because Certificate of Need typically regulates investment in new equipment and technologies. And CAR-T is not a piece of equipment or a technology, it's actually a treatment. It also involves almost no need for new capital investment or services at a hospital. It can be provided actually through a very routine procedure that healthcare providers already provide. So when the Michigan Certificate of Need Board stepped in and blocked access to CAR-T last December, we had 40 days, according to Michigan state law, to get the legislature to interject and repeal the Certificate of Need Board decision to allow for access to this treatment. So during those 40 days, it was really an intensive battle against the hospitals to persuade lawmakers that, look, this is not only just outrageous that healthcare providers in our own state would try to block access to an innovative healthcare treatment using the state Certificate of Need laws. Ultimately we were successful in getting the legislature to overturn the Certificate of Need Board's decision on that and allow patients in Michigan to access this drug. But it was a precarious situation, and it's something that no state should have to grapple with. And it's an abuse of the Certificate of Need process, which we've already established is an abusive practice anyway. Another story here in Michigan, also from the past year, is a story of a large hospital actually called Belmont Health, which is based just north of just north of Detroit, Michigan. And they filed a lawsuit to challenge action on behalf of the Certificate of Need Board when they had already been approved for plans to establish a 117-bed hospital in a village about 40 miles north of Detroit. That village they had identified as a limited access area, which is part of the Certificate of Need regulation here in the state. So that permitted them to establish this 117-bed hospital in that village. So they proceeded with those plans, began construction, were really already beginning to plan for an opening. And then the Certificate of Need Board stepped in again and reversed their practices, changed their interpretation of what limited access area requires, and said, you know, sorry, we know we gave you one understanding before, but it actually means that we require a minimum of 50,000 residents for you to establish, you know, services or a center in that area. And Oxford, this little village north of Detroit, does not meet that threshold. So the board actually prevented Beaumont from continuing to move forward with that small center, even after they made all of the capital investment. So it's just egregious what you see happening in the use of these laws and the way that they're applied. They're really weaponized. And oftentimes it's at the behest of the competitors in the marketplace, unfortunately.
Thank you. You know, as I'm sitting here, I'm sure some of the other folks listening are going to want to know which states remain kind of on either side of that line. So I don't know if one of the documents you have or that you could share with us would have that, because I think that might be helpful to us to reach out to colleagues in the states where they've successfully rid themselves of this unfair practice and perhaps arm ourselves moving forward. But what also struck me is now, during a time when we're experiencing this COVID pandemic, and we were very, very concerned about these CON laws. Now, all of a sudden, we've made some movement there. What do you think the likelihood is that we can build on this movement? And what have we seen when we have shown flexibility in some of these places? Let's start with Lindsay.
Sure. I mean, we know that con laws inherently limit the amount of healthcare available. So they were a logical first place to turn for lawmakers desperate for policy reforms that could help patients during this critical time. So for example, here in Michigan, our very progressive Democratic Governor Whitmer even embraced a temporary suspension of all of Michigan's con laws very early on in the state of emergency. When con laws have limited the number of hospital beds available or the number of ICU facilities that exist in a state, it's logical that these would be some of the first regulations that go. What doesn't make sense, though, is why they would ever be restored. And so we hope to see that this gives some momentum to the efforts that lawmakers have been deploying for decades to try to take these on. Unfortunately, they've always faced tremendous headwinds, namely from the hospital cartels in their states. And so we hope that that the political winds are now in the reformers' favor as we recover from the COVID pandemic.
Have you seen states maybe taking this opportunity as legislatures come into special sessions or sessions that were delayed and are now back in motion? Are either of you seeing states that are going to take this up, perhaps?
Yes, a number of states have filed legislation to either make permanent some executive order policies that have suspended con laws. That's actually, you see that popping up across the country. Other states have been debating bills that have already been filed in previous sessions to do that, or to at least take a crack at con and reform elements of their con laws. You know, a good state to point to if you're looking at, you know, just a blueprint for how to make some change happen is Tennessee. They were able to make tremendous progress on reforming a number of their con laws a few years ago. It was really one of the first cases of serious con reform in decades. And they went from being one of the most highly regulated con states to, you know, sweeping off half their con laws from their books, and they're looking to get the rest of them off the books in the ensuing, you know, couple of years here. So that's a good state to look at. But I know that it is a top priority for lawmakers around the country, and there's legislation all over the place to do it.
Great. Anastasia, how do you believe that we can get more robust reform of the con laws in light of these recent events? What are your thoughts?
Yeah, well, as Lindsay said, it makes sense that we're now seeing movement because even just to put up those overflow pop-up hospitals that we all saw in the news in New York City, you know, they had those overflow beds sprinkled throughout Central Park. The only way to do that was by suspending New York's con law. So they just had to. It's just no longer tenable to keep con laws on the books. And I think as a practical matter, it's going to be very hard to tell a lot of these healthcare entrepreneurs, thanks for your service here. Thanks for stepping in and filling the void. And now we're going to go back to revoking that, and you no longer have permission to operate. So I think we should, work through this opportunity to demonstrate to people the practical, real harms of con laws now, that those beds would not have been able to be put up without the suspension, and to extend that beyond. And, we often have a hard time getting legislative reform, but I actually find that litigation, of course, can actually act as a complement. A lot of people see it as some sort of adversarial thing, but it doesn't have to be. Sometimes it's just a way of giving the added push, the added pressure to showing the actual legal arguments against con and why these cons aren't just bad policy, but they're actually unconstitutional and shouldn't be on the books as a matter of constitutional law and fundamental principles. And so I think that litigation can act as a nice complement in some cases to legislative reform.
So we've talked a lot about healthcare, CON, but during COVID, there were probably other businesses and industries that were affected, and probably outside of COVID as well. But what are some of the other things to put in our minds for the con laws that really harm other parts of the industry and small business world as well? Anastasia, do you want to begin?
Sure. We often see con laws in the transportation industry because that's where they originated. They're actually, they started as applied to railroads back in the early 19th century. So when you look at it that way, you see how antiquated the economic theory is. I mean, they were really created for these industries with high startup costs that were more like a utility that take up a lot of room, where you maybe only need fewer of them. And yet now they've been extended down the line to modern forms of transportation. So we actually see them in industries like moving companies, taxis, limousines. I mentioned earlier, utilities, but also apprenticeship programs in California. So if you want to be an apprentice and eventually work in construction, if you want to go to an apprenticeship school, those schools have to get permission from each other. And I think the unfortunate thing about this is we're seeing, part of the COVID recovery is going to be, obviously the healthcare space, but also there's a real economic problem going on. People are out of jobs. And a lot of these industries that are regulated by con would be an easy path to entrepreneurship. So a moving company, all you should need to start a moving company is, to buy a truck and to have some knowledge of the city and some willingness to work hard and some arm strength, and you should be able to start a moving company. It is a quick path to entrepreneurship that requires very few resources. And yet in many states, you have to go through this certificate of need program to start a moving company. So I think it is important to look at other industries regulated by con, particularly in transportation, which historically has been a really good way for people to lift themselves up by the bootstraps and start, to create their own jobs, and look at opportunities for reform in those areas as well.
Lindsay, have you had additional businesses that you've been focusing on, other spots, or anything you'd like to add to the CON conversation?
Well, I think Anastasia really covered the breadth of how far-reaching certificate of need laws are and what their impact really means day to day and for people, at the really local neighborhood level. It's just important that these are exposed. I think con has been able to just survive under the radar for so many years because, as I see one of our questioners posed, how do we make this a sexy issue? Con's just not a sexy issue, and I think it just goes back to breaking it down into the most simplistic terms. This is anti-competitive. It's corporate welfare in its most egregious form. Any systemic scheme that picks winners and losers, whether it be through favors offered by the government or it be through regulatory schemes that just prop certain members of an industry up over others. those need to be looked at, examined heavily in the public eye, and they need to be reformed. So, I mean, the principles around the arguments we're making against certificate of need really can apply to a number of things. But I think the important thing is that these need sunlight. I think state lawmakers often don't know who even sits on the con boards. How are they elected or appointed? Who has jurisdiction to shuffle that board up? What authority do you have over them to call them to the carpet when they're doing things that are just completely outrageous? No, that was a real education experience we had to walk our lawmakers through in Michigan recently when we took on the CAR-T issue. So that's, I think those are the first steps that lawmakers should take if those haven't been taken already. Figure out how you can have sunlight hearings on these things, and just let more awareness happen over these laws and who's pushing them. I mean, really, it's you shouldn't want to be on that side of the argument. And so the more that we can draw out who's supporting these laws and why do they even want them in place to begin with, I think the more people are going to really understand why they're so important, how much of an impact they actually have, and they're going to care more about it. They're going to start, supporting their lawmakers in their efforts to repeal them.
I think the other thing when it comes to that particular question is a real sense of transparency, which I think is always helpful, particularly in healthcare, because it's so complicated. And so the more transparency we can bring, the better. But I think the stories are the other thing. It's really interesting. Less than a week ago, after I'd been asked to participate in this, so during that time, I got a phone call from a constituent, his business, providing services to disability people that needed them, was in an expansion. It was approved, but the vote hadn't been taken. One of the members on the CON board went away for whatever reason. And because of COVID, the governor hadn't had the opportunity to reappoint. Everything was tabled. He was completely stymied for like 3 months, waiting for this appointment. Of course, when we called the attention, then it got resolved pretty quickly. But it's that kind of a bureaucratic barrier that we really don't need and shouldn't have been necessary if they were complying with the other things that were needed when you're going to provide services to in a healthcare space. We shouldn't create additional hurdles for people to have to get over, and this certainly was one. But I think those stories, when those sort of hit you right in the face, it's hard for a legislator to ignore. So I think stories, real life stuff, really makes a difference. So at this point, and we've talked about CON a lot. I'm sure there are questions about it, but before we completely run out of time, there are other areas of healthcare reform that I think create real problems for individuals and are certainly on the forefront for state policymakers. And since we have some experts here, I think I'd like to have you talk a little bit about telemedicine. So Anastasia, what are some of the biggest obstacles that you see today facing telehealth?
I think the 3 primary barriers nowadays are bans, reimbursement policies, and licensure. So with bans, that's an obvious one. We actually see states where they ban the practice of telemedicine for certain types of medicine. So in Maine, you can practice telemedicine for things like osteopathic care, but for teledentistry, it's just completely banned. And actually this led to the sort of paradoxical result where the governor had said, we're urging people to, during COVID, to not go to physicians' offices for non-essential services, but feel free to engage in telemedicine, including teledentistry, when in fact the board had outright banned teledentistry. So bans are just an obvious problem that are problematic for telehealth. And even when there's not an actual ban, there are sometimes functional bans. So in some states, you can only engage in telemedicine if you have a pre-existing patient-provider relationship. And then they further require that in order to have a patient-provider relationship, you have to have an in-person meeting to establish that. But for those who want to access telemedicine across the state, or they want access to providers in other states, that's a functional ban, because the entire point is you don't want to have to drive somewhere else, across the state or across the country to find a provider and establish a relationship. I know during this outbreak of COVID, I use an app that's called Healthiest You. It's telemedicine, and they just connect you with the first person on demand. You don't have to have, only access to your primary care physician. My primary care provider is very hard to get into. I just want to be able to tap that button and speak to someone quickly. My 1-year-old daughter had a fever a couple weeks ago, and of course I was very worried, and I just wanted to speak to someone without having to go in. And apps like that facilitate that. They put you into contact with whoever's available. And so it's unfortunate in states where that sort of technology is outright prohibited. With reimbursement, we see that sometimes state Medicaid policies discriminate against telemedicine. They just don't reimburse for it at all, or they only reimburse for it under very narrow circumstances. So for example, they'll only reimburse if there's no physical provider near you within 15 miles, or they'll only reimburse if you go and have the telemedicine appointment in a physician's office. You have to go somewhere where maybe you go to an x-ray machine, and then you can also call into somebody else via telemedicine. And again, those things just don't make sense. They completely frustrate the purpose of telemedicine, which is not having to go somewhere. And then the third obstacle is licensure. Many states require you to be licensed in the state where the patient receives care. And of course, that limits out-of-state access, which is a problem given that 84% of providers are licensed in only one state. But I was reading an article recently that I thought was interesting about how, in order to practice telemedicine, some physicians are getting licensed in several states. And in fact, some are getting licensed in every state just so that they can transition to telemedicine pretty easily. And so I saw that there were only 6 providers in the entire country who were licensed in all 50 states in 2016. Now we have 14. So, it's good that those 14 are able to practice across the country, but we want to open that up. And I also think it's amusing about that, as I was reading about that. And there's now a whole cottage industry around facilitating providers into getting licensed into other states. So just as licensure itself is sometimes regulatory capture, now we see this other industry, that's budding up, that is also aimed at facilitating. It's capitalizing on these regulatory barriers, when wouldn't it just be nice if you didn't have to pay somebody else to shepherd you through the process, and you could just practice in another state because that state recognized that you are qualified to practice? So I think those are the 3 areas that provide the biggest barriers to telehealth right now.
Well, Iowa took a big step in the regulatory reform, so hopefully that's going to be helpful for that particular issue. But which states, just to follow up on that, which states do you see doing a really great job, and perhaps even which states are doing the very worst jobs in this arena?
Yeah, we often see Arizona heralded as a very good state for telehealth. Actually California is pretty good, which I think it's always surprising when I go testify places out of state, to hold up my own state of California as the pinnacle of good regulation. I mean, if you're worse than California, that usually means you're doing something wrong here. And then but there are others, usually I think it's like, they usually separate out into a third of states are pretty good, a third of states are middle of the road, and a third of states are pretty bad. And the bad ones very often include Arkansas, South Carolina. I know in Alabama, I think physicians are the only types of provider that are allowed to practice telehealth. So, you're cutting off telehealth to mental health services, which are extremely important. And especially right now during COVID, a lot of people have anxiety and don't want to leave their home to go to their provider's house. You're eliminating teledentistry, all these other practices that are really important and could be utilized.
Lindsay, I know that in Michigan, like a number of other states, the governor has suspended telemedicine regulations that, among other things, of course, interfere with people's practice. But comment on that, and are there genuine concerns that we need to care about in this as we move forward, perhaps even outside of COVID?
Well, I mean, I think it's just important to keep in mind that states have been allowing, at least in some fashion, the practice of medicine across state lines and also the practice of telemedicine for quite some time now. Some states have been ahead of others, as Anastasia noted, in doing that, and not all states have permitted it. But it isn't, we're not trying to reinvent a wheel here, or you know, this is not something that our healthcare system is unfamiliar with. It's really just about getting states to take the very logical step of embracing innovation. And you know, we've seen most recently with this COVID pandemic, there be some momentum and you know, sort of a place to start for some lawmakers who were just really picking good ideas off the shelf, even if it's just you know, for temporary practice, that we hope are going to stick. And this is, you know, this is really one of them. More than 40 states have now made it possible for expanded access to have, you know, expanded access to telehealth, and that includes providers licensed in other states. So I think what's most important now is that we champion these actions by people across the political aisle. We also talk and educate with, you know, folks, policymakers across the country about how important it is that we don't lose ground here, that we point out how these have been effective for people, particularly on Medicaid. I know, you know, we always want to be cognizant of the impact that healthcare reforms are going to have on the most vulnerable, especially. And those would include your traditional Medicaid enrollees. Those individuals right now are extremely high risk given the current circumstances. And in states like Michigan, where telehealth was expanded, at least temporarily, to being reimbursed for Medicaid patients, that's been a real boon to those folks, being able to receive care without having to leave their homes and potentially expose themselves to a really, you know, dangerous health scare, or, you know, put others at risk too. So we need to tell those stories. As you mentioned earlier, stories are really effective. So right now is the time to be gathering those, as states have really loosened these telehealth regulations, so that we don't just replace them when, you know, the scare dies down.
Well, I think that's a really important point. And I can tell you that it's also a huge issue for access, because whether you're, you know, if you're seeing a specialist that lives an hour or 2 hours away and you need something simple, especially if it's something simple, there's really a wonderful opportunity to allow people to utilize the telehealth to meet the needs of that, and not have to travel all that time when perhaps, you know, it's a difficult travel for an older person or something. I think it's just really important that we, you know, think outside the box, and those are really effective. I've done them. They are so effective. I really think there's an opportunity here. One of the questions fits really well in this very topic, Lindsay, and for both of you. Have you been working with governors during this time to make this move forward? Because it always feels like you need a champion for this. So whether it's someone in the legislature or during a time when legislative bodies maybe aren't engaging in session, have you been working with governors to make this happen and make it stick moving forward? Lindsay, if you want to kind of go from there, and then Anastasia can hop on.
Yes, absolutely. And this is an issue that doesn't need to be a partisan issue. So that's really one benefit of taking this issue on for administrations across the country, is that you can find support across both sides of the aisle, but you do have to be, you know, you have to be committed to getting reform in place for your constituents. And it's not easy. If it were easy, these wouldn't have existed for as long as they have. We would have made more progress than we have already. But yes, governors across the country, both Democrats and Republicans, have been exploring this, not just as temporary policy, but as permanent policy. State lawmakers have done the same. There's been numerous bills filed to make permanent some temporary executive order actions on telehealth. So just like Con, I think we're going to see more momentum for this issue and actually getting progress made on this issue over the next year. But that said, I think that there could be a tendency for, people to sort of just, policymakers have to, you have to move quickly. There's new issues cropping up. If you're not diligent, and if we're not diligent as folks who can educate the community and bring the research, they can very quickly just settle back in to the status quo. And there are definitely special interests that would like to see that happen. So just making this top of mind for policymakers for the remainder of this year, going into 2021 legislative sessions, make the commitment now, get those stories developed now, create a strategy for how you can not lose momentum over the coming months and year, but rather, use the momentum we have now to get reform in place.
Anastasia, one more thing for you to think about as you answer this question. I've always, looked for ways to kind of bring cost savings into this argument. And as you have studied this and worked with this, where are there areas where this does accomplish some efficiencies, where we do perhaps save some resources?
Yeah, well, I'll start by following up on that previous question about governors, because I think that is critical, especially during COVID. We've seen it's critical to work with governors to suspend things now because these laws need to be suspended immediately, and a lot of legislatures weren't in session. And so we've been working with governors. But even outside of COVID, working with governors is very important because, we were able to pass con reform for transportation in Nevada a few years back, and the governor actually vetoed that bill. So, you see why it's important, to reach across the aisle and at all times be working with governors and the legislature to make sure everybody's on the same page about, the policy issues and why they matter. And in so doing, I was really struck, Speaker Uppmeyer, by your comment about how important stories are, because that's so true. When people hear policy, all they hear is, oh, there's fewer services, or it's all sort of sanitized, data. And they don't realize that it's not just about, fewer buildings. It's not just a building where the service isn't being provided. On the other side of that, let's say MRI machine, one is the consumer who's being denied access. And there are actually, real stories about people trying to find a neonatal intensive care unit and being unable to, and very unfortunate situations that have happened because of that. So consumer stories, but also on the flip side of that is the story that there's a provider on the other side of that. And these aren't necessarily all, big wealthy people. A lot of times it's people who are just trying to get by or start something new and innovative. For me and our client, Philip Truesdell, he's a self-made man who started with one ambulance, and still he has 7 ambulances, and that's great. But, it's not as if, he really needs this ability to earn a living. And so I think it's important to tell those stories. And we have found that that's been very persuasive. And along with that, to answer your question about cost saving, again, the data just bears out that healthcare costs are higher in states with con laws, that these drive up the costs, because they drive down supply, then they necessarily keep prices artificially high. And of course, you're increasing the cost of, you're upping the barrier to entry. You're making it harder to enter the market because the process is so expensive and onerous. So to get started up, you're imposing costs at the very outset. And there's a lot of good data on that from a lot of organizations that just show that this isn't hypothetical, it's real.
Well, Josh, one of the things that I would like to tell you is the next time we do this, we need to have 2 hours. But we've got a few minutes left, and I wanted to go back to you for a moment, Josh, to see if there are questions that I have not seen, because I want to make sure we barely scratched the surface on some of these topics. But let's see if there's a question or two that we need to do.
Sounds good. Well, so we had a few questions posed, and Speaker Uppmeyer, were you seeing them pop up on the chat box?
I was seeing some of them, but I wanted to make sure I hadn't missed some.
Actually, I think we hit all of them. We had a few questions.
Oh, good.
at Emory, and we were able to easily get them into the conversation. So,
Well, that's what I tried to do, where they fit. So I wanted to make sure. So, so just to kind of close this out, I'm going to ask for 60 seconds, or I think that's perhaps what we've got, is 60 or 90 seconds from Anastasia and then Lindsay to do your wrap up, because I want to make sure that we're hitting on the things that you wanted to talk about today.
Yeah, from my perspective, a lot of the COVID policy discussions have centered around, and a lot of the policies themselves have centered around flattening the curve. But there's an alternative to that, and that is boosting supply, or at least they work in tandem and they complement each other. So in addition to policies that flatten the curve, we can focus, there's no reason to think of supply as static, and we should focus on policies that allow healthcare entrepreneurs to boost the supply, to change to dynamic circumstances, to innovate quickly, and to help solve the crisis that way. So I think we should never leave that out of the conversation. And, you know, the most critical policies right now, I think, are the ones we've covered: telemedicine, absolutely, con laws, scope of practice laws, licensure reciprocity, things like this. Again, let's just trust qualified people to do their job well. I mean, these people are qualified, and let's let them practice to the extent feasible, so long as they can do so safely, and get red tape out of the way.
Lindsay.
Sure. Where, you know, I echo everything Anastasia said. Absolutely. You know, at the Mackinac Center, our work on healthcare always focuses on expanding access, quality, and affordability of care. So I think there are, you know, about 6 things that we've come up with that lawmakers can do to achieve those goals over the next year. So that's pass legislation that would make permanent any temporary suspensions of certificate of need laws, reform scope of practice requirements by codifying any temporary, you know, loosening of those restrictions implemented by a governor. Pass legislation for expanded telehealth access, as we've talked about, removing licensing requirements for medical personnel that are just arbitrary, unnecessary, or prevent them from practicing to the top of their skills and training. Increasing the duration and flexibility of short-term limited duration health plans from 3 months to 12 months. That's to be in compliance with a new Trump administration regulatory change that restores these plans to their original versatility. President Obama actually restricted those heavily. Those plans are very, very helpful for individuals who are in school and between jobs. They're very cost effective. And that's a technical change that lawmakers can make that will have big impact for people. And then lastly, pass legislation to protect patients against surprise medical billing. You see that issue happening across the country. I know lawmakers are increasingly dealing with people from their districts who've been taken advantage of by that process. Not all reforms are created equal. That's a very complicated issue, but if you're interested in working on that, we would be happy to work with you on that and to educate you about what reforms are the best forms of law to put into practice there. But that's our agenda, what we're working on with lawmakers in Michigan and across the country. But, you know, like Anastasia said, let's preserve the good, build on that, and look for how we can expand those principles into other areas of healthcare more broadly.
Well, thank you both for joining us today. This has been a real pleasure for me. Thank you to Mackinac Center for Public Policy and to the Pacific Legal Foundation for providing your services to us today and hearing stories is my takeaway. And for those of you listening, please reach out to these super smart ladies to help you as you tackle these tough issues. And actually, we have a couple topics that we could do even more with licensure and so forth, but we'll save those for another day and work with this. Thank you both for being here. Thank you.
Thank you.
Thank you.
Thank you, everyone. And that wraps up this workshop for the day. So once again, I just want to thank Lindsay and Anastasia, both from the Mackinac Center and from Pacific Legal Foundation, for lending your expertise for our legislators today. This is the last session of the meeting today, but we will be kicking off tomorrow, 10:30 with our Suburban Caucus meeting. And then at 1 o'clock, we are doing a workshop on education choice. So thank you everyone once again, and
Bye.
we'll see you soon.